السلام عليكم، وبرحب بحضراتكم جميعا في الويبينار الثاني لاتحاد الجامعات العربية للأشعة. Dear colleagues, good evening. On behalf of the Pan-Arab Association of Radiological Societies, abbreviated as PAARS, I would like to thank our distinguished speakers and to thank you all for attending this webinar, and also to thank the organizing company ICOM for the good organization. I'm pleased to moderate this webinar that highlights an important issue about prostate imaging. As you know, high quality prostate imaging reporting and data system by RADS based on multiparametric MRI should be performed before prostate biopsy in most men who are suspected of having clinically significant disease and are likely to be offered active treatment. Men proceeding to biopsy after MRI have indeterminate to high likelihood of disease, that is to say by RADS category 3 or higher. For biopsy naive men, a combination of systematic and targeted biopsy should be performed. Only targeted biopsy are needed in men with persistent suspicion after prior negative systematic transrectal ultrasound-guided biopsy. High-strength evidence shows that MRI in biopsy-naive men can reduce the number of men who need prostate biopsy and can reduce the number of diagnoses of clinically insignificant cancers that are unlikely to cause harm. Men proceeding to biopsy after MRI and in men with prior negative biopsy results who remain under persistent suspicion, MRI improves the detection and localization of life-threatening prostate cancer with greater clinical utility than the current standard of care systematic transrectal ultrasound-guided biopsy. In this educational webinar, it is my honor and pleasure to introduce two eminent speakers, Professor Haitham Shibel from Egypt and Professor Anwar Badani from UK. We will start with Dr. Haitham, who is Professor of Radiology in Urology and Nephrology Center at Mansoura University and in Armed Forces College of Medicine, Ministry of Defense in Egypt. He is the founder and Secretary General of the Egyptian Society of Genitourinary Radiology and biomedical researcher in Harvard Medical School in USA. Dr. Haitham is an expert in prostate imaging. He has been extensively trained with leaders from NCI and NIH in USA since 2012. His presentation on BIRADS, a simple guide for proper reading. And we are looking for the presentation. Please, Dr. Haitham.
Thank you, my dear Professor Dr. Tari, and thank you for PAARS committee to invite us to sharing this webinar. Now I will start to share my presentation. So I thank you all of the attendants and all the PAARS committee, and also special thanks for Professor Badani to accept our invitation to share us this important topic. And I will start with to give a simple and a basic guide for multiparametric MRI of the prostate and how can we interpret for this examination. I have nothing to disclose. So some statistics about the Middle East and Egypt. Prostate cancer worldwide is considered the commonest cancer after skin cancer all over the world. In Egypt, it represents about 4.5% in the last statistics and represents the fourth most common cancer since this is the last statistic updated 2012. In the Middle East, represent about 3.7% of the cases, and worldwide, for example, in 2020 year, there is a new almost 1.5 million new cases discovered. So it is a wide cancer prevalence should be worth to be studied and to achieve a proper pathway for diagnosis. The question is all prostate cancer significant? And the answer is no, because a prostate cancer has a special unique features, may differ from many cancers in the human body. It's not all its types, it's not a lethal cancer. Some of the cancer, what we call indolent cancer, and it represents about 30 to 40% of the discovered cancer. And this indolent pattern means that the patient doesn't need active management or active intervention. So it's very important to discriminate or make a risk stratification between this group of indolent cancer, which doesn't need active management, with the other group of patients who has significant cancer. Those patients have significant cancer, and significant cancer means active management and active intervention. If we go back, especially before the 2012, we find that the classic diagnostic pathway of the prostate cancer, as you see, rising PSA, suspicious digital rectal examination, patient referred to the TRUS, and the TRUS results either positive or negative for prostate cancer. And this approach, it has a weak sensitivity up to 50%. So we need another tool to cover the diagnosis and detect the significant cancer lesion, especially with its wide prevalence, as I have mentioned before, alien. Starting from 2012, the first promising trial to establish what we call the PAARS system. This is established by the European Society of Urogenital Radiology, and developed a version 1 of the PAARS system, and developed by version 2 2015, and modification of the last version 2.1 in 2019. And this is with collaboration with American College of Radiology, ISUR, and the Admitech Foundation. So now this technique, rising the sensitivity of the detection of significant cancer up to 90% with the highest PAARS score system. So it's considered a big achievement for the diagnosis of the prostate cancer. So knowing the PAARS and the technique of the optimum multiparametric MRI examination became essential in this era. So exactly what's PAARS system? PAARS system, it's as a whole RAD system in the body, need to make detection, localization, characterization, and the most important, risk stratification to discriminate between the patients who should take active management and active intervention, rather than patients should go under surveillance because they have insignificant or what we call indolent cancer. And risk stratification, I think it will be covered in the lecture with Professor Badani. So here we need to know what's the current situation in our area, in the Gulf and in Egypt and in the Middle East. The current situation here, we have two issues. The first issue, urologist minds, and the second issue is the radiologist minds. This issue, radiologist minds, we need to convince them to change their classic paradigm from PSA, DRE, and TRUSP to shift it to implement MRI before biopsy. We don't have actual statistic for this to know what's the rising, but I can say with personal experience, the awareness about this step now become increased more and more in Egypt and especially in the Gulf area I'm talking about. They became request MRI before biopsy, but we don't achieve the optimum requirement yet. The second issue, for example, UK, this is maybe an old statistics. In 2018, the request of MRI became 80%, and just a while I asked Professor Badani, they told me almost now in 2024, 100%. And this is very great. We hope to achieve this percentage near. The second issue is radiologist training, and this is our task and our job in ESGR, Egyptian Society of Genitourinary Radiology, with collaboration with the Mother Society, Egyptian Society of Radiology, to make this awareness of the importance of the training of the radiologists and increase their skills and enhance their capabilities regarding the training and how to report the PAARS system. So let us go through the technique of multiparametric MRI, what should be used, the sequences should be used. We have three main sequences, T2 sequences, diffusion and ADC, and dynamic study. And in some situations, we use T1 sequence. This is for assessment of lymph node, assessment of bone marrow, assessment of hemorrhage. In T2 sequence, this is considered the anatomical sequence to assess and evaluate the whole prostate gland, and it has a special feature to become the what we call the principal or the dominant sequence for detection of the cancer in the transition zone. It should be high resolution. The basic sequence is axial. The current guidelines say that it should be at least 2 orthogonal planes, but in my recommendation, I recommend 3 orthogonal planes, axial, coronal, and sagittal should be taken as a routine. Regarding diffusion, the minimum p-value shouldn't be less than 1400 or more, according to the capability of your machine. ADC values not standardized yet to give a clue about this lesion is cancer or not. So we cannot rely on it. There is a synthetic p-value which can be used. This is a post-processing p-value after the examination finish. You can use a higher p-value than 1400, and in this situation, it's useful if you have this option in your machine. Lastly, the dynamic acquisition. Dynamic acquisition or dynamic study in the current era or in the last you can say last 5 years especially, we don't use it as a routine, so the examination turned its name to biparametric, using just two sequence, T2 and diffusion sequence. However, the guidelines still recommend to use dynamic studies and contrast study, especially if there is in the novice institution or you don't have enough experience to rely on both sequences. The most important is to use the temporal resolution window between 10 to 15 seconds based on the machine capabilities. These are a quick hint about the technique. So what about the PAARS category and the concepts? This is the image of manual of the manual. I highly recommend to do download. It's a free manual to download from the American College of Radiology or from the Azure Society. It will be very useful for you, and it almost contains everything you will need to know. So PAARS has 5 main categories from 1 to 5. You shouldn't miss the PAARS 4 or PAARS 5. The most important 2 groups are PAARS 5 and the PAARS 4. Why? Because this means that you have a likely significant cancer to be present in this case. And PAARS 5, it's very high to be present cancer in this case. So it's very important, don't miss those lesions because they have percentage to be a cancer. Okay, PAARS 4 and PAARS 5. And actually, the discrimination between them is very easy because it relies on the size of the lesion. If the size of the lesion less than 1.5 centimeters, so it will be assigned for PAARS 4. If more than 1.5 or equal 1.5, this means that you assigned PAARS 5. And PAARS 3, this is considered the gray zone of the PAARS system. It means that you don't sure is the lesion you dealing with is a cancer or not. And usually the next step will based on NDT decision. While PAARS 1 and PAARS 2, we consider the benign variant of the prostate lesion, either in the peripheral zone or in the transition zone. So again, the most important PAARS category are PAARS 4 and PAARS 5. Another important concept of PAARS version 2, which is the dominant sequence. Dominant sequence, it means that we should know that 70% of cancer present in the peripheral zone and about 30% in transition zone. So most of the time you are dealing with a case of peripheral zone cancer. So dominant sequence means this sequence, it has the upper hand to make the final PAARS scoring grade, which is 4, 5, 3, or 2, 1. So dominant sequence in the peripheral zone is the diffusion sequence, while the in transition zone is T2 sequence. So let's take a look at the scoring system and how can we scoring the PAARS. The idea of a scoring system is to score every sequence. T2 has its own score from 1 to 5. Diffusion has its own score from 1 to 5. And contrast study has a special scoring, which we just say positive or negative. It's not like the other sequences. So we need to score each sequence separately and make final score. So let's start with the peripheral zone. The common is common. Let's start with the peripheral zone. The peripheral zone here, we can notice that this is a peripheral zone. We can see the nice homogeneous signal, high signal intensity of the peripheral zone. This is the margin of the peripheral zone like that. It's traced by the arrow. I don't know. I think the arrow maybe, I don't know if it's point, but I will use the laser pointer here. Okay. Okay, so I can use, this is the margin of the peripheral zone. And actually, most of the time, you will not see this homogeneous signal intensity in most of the patient. But the message here, signal intensity here is the dominant bright signal. This is the rule, dominant bright signal. So in this situation, we can say assign it's a PAARS 1 on T2. Now we are talking about T2 sequence. So this is a T2 PAARS 1 because it's normal. And I will use the descriptive terms which come in the manual, which I browsed earlier. And I would recommend you in your report to use these descriptors because it becomes standardized and you can familiar with it. It's uniform hypersignal intensity. This means normal. In the matter of fact, you will find this is the most variant you will find in the peripheral zone, which is assigned for PAARS 2 category. You will find a linear low signal intensity like that, or a wedge shape like that, or multiple linearity like that. You can see all these linearity of low signal intensity. It's not homogeneous as in the first case. All these other pattern of the peripheral zone. You can see here a wedge, another wedge shape in the left side of the peripheral zone, another area here of low signal intensity, and another wedge shape here. These are the commonest pattern you will find, and all these represent the entity of prostatitis or benign finding. So it's assigned for PAARS 2. So the question is, which the typical cancer looks like, which is important, which this is our concern, PAARS 4 and PAARS 5, the significant cancer. Okay, before shifting to the significant cancer, I will continue for PAARS 1 and PAARS 2 for diffusion sequence. We are talking about the T2 sequence. This is a diffusion sequence. We can notice that normally this is the p-value sequence and this is the ADC map. In the PAARS 1, there is no any restriction, and ADC there is no any low signal in the peripheral zone. This is a completely normal. And again, I taking this as a screen capture from the manual to show you the manual is a very good starting index for you. If we assign the PAARS 2 in diffusion, this means that you have a little bit restriction, but not definite area of restriction, because again, it take the linear shape or even a wedge shape, hypo-intense in ADC or a slight hyper-intense on the diffusion. So all these the variance of benign findings. So again, what's the typical cancer looks like? This is the most important here, significant cancer. So in significant cancer, we have a magic word. You should keep in mind. The magic word here is the word focal. Look always for a focal low signal intensity. And the word focal means that you can trace this lesion and it almost circumscribed or rounded lesion with homogeneous low signal intensity, either moderate or marked hypointense. Okay, so if we look at this image, we find that this is the level of the near to the apex, and this is the right side of the peripheral zone, and this is the left side of the peripheral zone. We can notice this is the dominant signal here is the bright signal. Okay, however, it's not very bright as the typical case as I have shown for you. But here on the left, we have another relative low signal intensity, but it looks like a wedge shape. So it is not the circumscribed pattern which I have concern. But if we look here, we'll find that this is a very circumscribed low signal intensity lesion. So this is the focal lesion which I should have concern about. Okay, if we look at this case, also we have this is a level of the prostate apex because we have a symphysis pubis here now. So we can see this is the dominant sequence pattern, dominant signal pattern, bright signal. However, there is always linear signal intensity. This is not of our concern because the linear signal, low signal intensity, now we know it's a benign finding. But if we looking for the word focal or circumscribed, we can find a well-defined focal low signal intensity here at the right side of the apex. This is very important. This pattern is very suspicious here, and here. So when I assign this lesion to PAARS 4 or PAARS 5, it relies on the size. If this lesion less than 1.5 in the greatest dimension, so it will be assigned for PAARS 4. And if this one is assigned 1.5 or more, so it will be PAARS 5. So discrimination here, it relies on the size, is very easy. Another important point regarding the PAARS 5, whatever the size of the lesion, even if the lesion size less than 1.5, but the lesion extends beyond the prostate confident or the prostate margin, get outside the prostate, this means that this lesion become invasive and means what we call extra-prostatic extension or extracapsular extension. This means should be assigned as the most invasive pattern of lesion and the PAARS 5, whatever the size of the lesion. So it's very important. This is the typical pattern of the peripheral zone cancer on T2. So what about the diffusion? Don't forget that the dominant sequence of the diffusion of the peripheral zone cancer is the diffusion. So here also we have a typical restriction pattern. This is here a very restricted pattern on the left side of the prostate and a typical marked low intensity pattern in the ADC, the corresponding side. So this is a very positive diffusion sign. This should be assigned as PAARS 4 or PAARS 5 based on the size. Again, if we find here, this is a very restricted lesion at the left side, and there is a very low ADC signal intensity. And it's obvious that this lesion larger than the 1.5, so it's assigned for PAARS 5. So as long as the lesion has obvious and marked restriction, should be have a very special concern. Or again, don't forget focal. And what about transition zone? Transition zone, it has a different unique features. Transition zone, it is the site of development of PPH nodules. And PPH nodules, as we can see, this is the typical pattern of PPH nodules. It's just nodule and surrounded by a typical low signal intensity capsule like that. If we can see, this is all multiple prostatic PPH nodules associated with capsules. Most of them has incomplete encapsulation. And this organization of the transition zone reported in the literature as organized chaos. Why organized chaos? Because the normal pattern of transition zone is heterogeneous due to presence of these multiple different signal intensity of PPH nodules. However, it's still organized because the dominant feature here is multiplicity of the nodule. No other lesions we can identify. If you like the art, and if you're drawing the art, you should remember the charcoal. And this is a piece of charcoal who, when you make it like in the piece and you can whip it by a piece of cotton, you can give what we call the charcoal erase sign. If we find this organized, a part of the transition zone is whipped by like a piece of charcoal, so therefore we have a suspicious to be a specific suspicious focus here. So the rule is different here from the peripheral zone. Peripheral zone searching for focal circumscribed lesion, but this is not applied for transition zone. Why? Because all the transition zone should be circumscribed nodules and the focal nodules, which is a normal. This is the normal inherent features of the transition zone. So what's the typical cancer looks like in the transition zone? We can imagine this. This is the organized chaos in the posterior part of the prostate. This is a large nodule surrounded by a capsule and multiple nodules, some of them with nodules and some of them incomplete and so on. However, in the anterior part of the transition zone, we find the charcoal erase sign. This is like the organized chaos disappear. Something whipped it, erased it. Why? Because there is a new soft tissue here. Soft tissue not belonging to the system of the transition zone. So this is as very suspicious. It's what we call the lenticular pattern or non-circumscribed region. And don't forget that we are dealing with transition zone. So the dominant sequence here is the T2. This is which will determine in the most of the cases the final PI-RAD. If the lesion less than 1.5, we apply the rule, it will be PI-RAD 4. Another lesion here, this is the organized chaos posteriorly. However, anteriorly, there is a whipping of this chaos. There is no such fine details here. This is just a soft tissue mass-like lesion here. So this is a very suspicious area, especially if we can notice that this lesion doesn't respect the outer margin of the capsule, and it could be has extra prostatic extension. So it is an invasive pattern of transition zone cancer and assigned as a PI-RAD 5, sorry. What about diffusion? This is the same. This is restricted pattern, significant restriction in the p-value and significant reduction of ADC. The same here with larger size. So we have a PI-RAD 4 and PI-RAD 5. So what are the benign findings of transition zone here? We shouldn't miss. This is what we call the organized chaos, and this is assigned as a PI-RAD 1. It's a benign finding, no need. And all these different pattern of transition zone, we can see here a large nodule. However, it's almost has its entire capsule. Another one nodule almost has its entire capsule, like that. So it's assigned for what we call typical nodule. This is the classic picture of the typical PPH nodule and assigned as PI-RAD 1. PI-RAD 2, which is here, have a different nomenclature in the PI-RADs. We can say this is a nodule, but it has incomplete encapsulation. It's not surrounded by the capsule all over the side. So it's incomplete, but it will be assigned as PI-RAD 2, or we have a nodule, but without any encapsulation. There is no encapsulation, or just an area of low signal intensity between the nodules. And this is all these variants of PI-RAD 2. And this is the diffusion. There is no definite restriction of the PI-RAD 1 or PI-RAD 2. And ADC also, there is no definite reduction of ADC. And these are the organized chaos of the different heterogeneities. You can see there are multiple area of low signal intensity. However, we cannot rely, that is why we cannot rely on diffusion on the transition zone. What about the gray zone, which is the PAARS-3? This is when you find the diffusion. This is applied for both transition zone and peripheral zone. This is applied to when you find that the diffusion is not comparable between the ADC map and the p-value. It means that when you find lesion like that, it has a mild hypointense ADC, and on the p-value, almost there is no restriction. So it's not comparable as PAARS-4 or PAARS-5, as we have seen in the typical cancer. So in this situation, we assigned PAARS-3 the gray zone. This is the same. There is significant drop of ADC. However, almost there is no or mild increase of p-value restricted diffusion. So it be assigned as a PAARS-3. The last of the PAARS, which is the dynamic contrast. Here, the scoring system will differ. It's just positive or negative. The clue is the suspicious area you find on T2 or diffusion, the corresponding area in the dynamic study should be take early enhancement compared with the remaining of the prostate. If you find this pattern, you can assign it's a positive dynamic study. And if you will not find, so it will be a negative dynamic study. As we can see here, this is ADC map, very low ADC. This is very suspicious, okay? And in the same time, the corresponding, this is enhancement, significant enhancement compared to the remaining of the prostate. So it is a positive DCE. How to report the final PAARS? You will use the dominant sequence. If we have a peripheral zone, if you assign PAARS-1 for the dominant sequence, so the final PAARS will be PAARS-1. And the same of the PAARS-2. And when you have a PAARS-3, the gray zone of the PAARS, in this situation, you need to inject contrast. This is maybe the only indication to inject contrast. That is why it has not a popular use in the current or in the last years. If the DC is negative, it will remain PAARS-3. It's positive. It should be upgraded to PAARS-4, and PAARS-4 dominant sequence, it will be assigned as a final PAARS-4, the same as PAARS-5. What about transition zone? The same PAARS-1, PAARS-2, even with diffusion graded 1 to 3, so it will be assigned to a PAARS-2. If assigned to 4 or 5, in this case, you should upgrade the final PAARS for transition zone to PAARS-3. What about PAARS-3 assignment? So 1 to 4 is still PAARS-3, but if you find that the diffusion scoring is 5, so it should be upgraded to PAARS-4, and PAARS-4 the same, PAARS-5 is the same of PAARS. So before reporting of such cases, we need something. Before start reporting for every exam, you need something you receive, something you will give, and something you wait. You receive the PSA. So keep in mind always when you perform an examination, you should have a PSA for the patient. And you will give the clinician the PST, prostatic density, and this is rely on the PSA and the prostate volume. And after final decision, especially if you report to the final PAARS-4 and PAARS-5, the patient should be referred to the biopsy, and you waiting the Gleason score, because it's one parameters now to say it is a significant cancer or not. So the steps of diagnosis, detection of the lesion, localization of the lesion, individual scoring of each sequence, and finally the overall scoring to give one of these categories. Finally, what you would like to assess, start with the peripheral zone because it harping the most of the cancer, then transition zone, central zone, and anterior fibromuscular stroma. I will give a hint in the case model. So now I will stop my sharing. Dr. Tariq, please. I will stop share my presentation trying to browse a case.
Okay, Dr. Aysam. Thank you for this comprehensive, it is a real simple guide for proper reading.
Thank you, Dr. Tariq. I will. Okay, I think you see my DICOM viewer now. Okay, you see my DICOM?
Yes, doctor, we can see it.
Okay.
Yes, hi, Samir.
Okay, so in routine brackets, usually I'd like to use a special layout, maybe a 6 layout, but I will use 4 layout for the current. But this indicates the main sequences we use. This is the T2, and this is the p-value, high p-value, and this is the ADC map, and this is the contrast study. This is a classic case for teaching. However, as I told you, we don't use the dynamic study now as a routine, but I'd like to show you, and the first time I'd like to take an idea about the prostate as a whole. So I prefer to take a look about the T2 because it's the key anatomical sequence. So I'd like to scroll the lesion, scroll the prostate from, and I'd like to start from the apex, because the apex, in many cases, in my experience, and I found that the apex usually harbor lesion, and usually this is one of the overlooked areas you can miss this lesion. So start with the you might miss. This is the apex of the prostate. Why we apex? Because we're at the level of the symphysis pubis and the root of the penis here. This is the starting of the apex of the prostate. So I'd like always to start from the blue to base of the prostate, which is the landmark. It's the bladder. We have now starting to see the peripheral zone on T2, which has the characteristic bright signal intensity. So I can trace up and check. Of course, you can notice that this is different. There is no way of on the peripheral zone. Remember the magic word. You are looking for a focal area or circumscribed low signal. Okay, but if you find multiple linear or wedge-shaped linear signal intensity, so this should be not concerning, because this is another pattern of the not cancer, usually prostatitis. We can see here, this is a low signal, diffuse low signal area of the prostate. Okay, this is the mid prostate level here. And this is, you can say this is the normal on the left, the normal peripheral zone here. It has some linear. Also here, peripheral zone signal intensity is high. However, in the posterior part of the peripheral zone, it has a significant, it has a relative low signal intensity. But ask yourself, is it focal or diffuse? Okay, so it's obviously that it is not focal, and it is not so much drop of signal. So I don't have a real concern regarding this region. So I'll go up. Now I'm directed to the base of the bladder, so the base of the prostate, because the bladder is started to seen and the seminal vesicle is started to seen. So this is the base of the prostate, bladder here, and seminal vesicle here. And in this part, we can find another interesting part of the prostate, which is the central zone here. This is the central zone area of the prostate. I don't know if the contrast very well. Okay, and anteriorly we find that this is the region of the anterior fibromuscular stroma. Okay. So I think that there are in many cases, so we have in the peripheral zone on T2, I cannot see a very suspicious area. It's not focal area, but don't forget, transition zone is not the dominant sequence for the peripheral zone. So I should rely on the diffusion sequence, not on T2. But I will give a scoring system for the peripheral zone, for this case, on T2 now, PAARS-2, okay? So let us go to the transition. So I will come back to, this is the, usually when you take a look, so you can scroll for the cases synchronously to detect any suspicious for the peripheral zone. in the beginning, try to focus on one zone, not in the both zone. And when you are sure preferred zone is a free, okay, you can shift to transition zone. This is at least for the beginning of your reporting process. Okay, so even here in the diffusion, I look here at the p-value and the ADC value. I cannot find a specific restricted area or a specific low signal area. So I don't have a much concern about the peripheral zone now. So I can shift it to the transition zone here. So I can make highlight and magnify the lesion on T2, especially T2 is the dominant sequence here, and I will revise each sequence again from the apex to the base, which is my favorite technique. And my eye is fixed at the transition zone. And if we can notice that, you see here the prostate transition zone in the center, and this is here the organized chaos which should be seen. However, it's not complete all over the transition zone. There is something here. There is something like what we have said before, erased charcoal sign. This is like something erased the organized chaos to become featureless. There is the typical feature of the lenticular feature of the transition zone cancer. This is a soft tissue mass here. This is taking the lenticular shape pattern of the prostate and almost take the anterior part of the transition zone. And we can go up to see its limit. Yes, it's extend almost to the mid-level of the prostate here. I can mid-level of the prostate and almost before the apex. So it's extended from the mid-base to the apical level. Is a large lesion. It's more than 1.5 lesion. So I will assign this lesion for this PAARS for T2 for PAARS 5. If we check for the diffusion and ADC map, I can focus on two windows. I don't need to change, I don't know to share out, but if you can see here in the bottom of the windows here, we can say that this in ADC, there is a significant drop of the corresponding side of the T2. This is very important to pick the corresponding suspicious area. And this is in ADC, this is a marked low signal intensity of ADC. However, on the p-value, there is a restriction, but actually, I cannot say this is a marked restriction. And this is why we can give diffusion, maybe a PAARS 3, because the degree of diffusion is not comparable to the degree of ADC reduction. But when he give here PAARS 5 and they give here PAARS 3 or even PAARS 4, if you didn't measure the size, you will finally score by the dominant sequence. Ask yourself which is the dominant sequence for transition zone. It's PAARS, it's a 2-2 on T2 sequence. So the highest score of the dominant sequence should overcome the other sequences, okay? Even if the diffusion is higher, you scored it higher from the score according to the previous map we illustrated. So this is PAARS 4 final score, and this is, we can say, PAARS 3. The final score will be PAARS 5. So in this case, does we need to inject the patient with contrast? Actually, no, because it will not change the final PAARS. It could be changed on the peripheral zone, but not will change the transition zone. But I will check what about this case regarding the contrast here. We can see here it's a little bit here higher in contrast, but it doesn't concern me regarding the dynamic contrast study. Even it's higher or equal, I can assign negative or positive for transition zone. It will not affect my final score because the final score will rely on this dominant sequence on T2. So this is just to take a look and take a flavor how to report and define the case. These are the cases shouldn't be missed. please shouldn't be missed for PAARS 4 and PAARS 5, because these are the most likely to be a significant cancer. And if you miss, the patient will be deteriorating. Okay. I don't know, Dr. Tariq, if I have more time for another case, or we come to end.
You have 5 minutes.
Okay, I will try to. Okay, I think that you are seeing my share screen now. So we'll come to the rule. This is T2. I will make it revise again starting from the apex to the base. This is another case, so we can find that. Don't know, the contrast is good, but I will start from the apex to the base. Again, now this is the seminal vesicle and the bladder, so we are at the base level. I will come back. Okay, so we can notice that here, this is the right side of the peripheral zone, which has homogeneous signal intensity, and this is the level of the apex because we have on the symphysis pubis. And if we notice that on the left side, there is no such pattern of the normal signal intensity. There is something here of low signal intensity, and the question is it follow the magic word? Is it focal or not? If I can trace this lesion, yes. I can say it's circumscribed, and I can say it's focal, and it's markedly low signal intensity. So it's a very suspicious area here and very suspicious lesion. And this pattern can extend upward. If you notice that this is another one of the variants of PAARS 2 we have mentioned before, this is the wedge pattern, and this is a relative low signal intensity on the right side. If we compare to the left side, no here. However, there is much image degradation quality, but even if presence this quality, we can, if we use the magic word, if we stick to our mind with the focal circumscribed marked lesion, we can detect the abnormality in a lesion like that. So we are here for the peripheral zone. I'm checking the anatomy as a whole, and I found a very suspicious area. So ask yourself, what's in which area? It's a peripheral zone. So I should rely on the dominant sequence, which is the diffusion sequence. So I will adjust the windowing levels. Very important to adjust windowing level. It's 1400 if you can adjust for diffusion. And I will scroll. This is starting from the base. I will come to the reverse and see. We can now see a very important note that the corresponding area here on T2 has a very restriction on diffusion and a very low signal intensity on ADC. And obviously, this lesion is much more than 1.5. So I will grade this lesion as a PAARS 5 on T2. I will grade this lesion on diffusion as a PAARS 5 because it's much more than 1.5. Okay. And of course, if I can see one of the important sequence here, you should see if there is extra capsular extension or not. And you can, because the image quality may be degrading this part, but I think there is extra capsular extension here. So despite of the lesion size, as long as there is extra capsular extension, you should assign for the highest PAARS. This is the region of the neurovascular bundle, and this is large area which is seen infiltrating the left neurovascular bundle. So it's PAARS 5 at all levels. But I will give you the flavor here of see the PAARS 5 diffusion restriction. So the question is, does we need to inject the contrast for the patient? In the clinical practice, we don't need, because now the dominant sequence is very enough and even on T2. But, okay, but I will give you here, this is the contrast. Let us check if there is a positive DCE or negative DCE. Yes. Oh, it's very positive DCE. The bright signal of contrast enhancement here, if we compare, I can magnify this sequence. This is the dynamic study. We can notice that this is the typical pattern we see on T2 and diffusion. It's very positive. It's very take early enhancement compared with the remaining of the prostate. So it's very positive, okay? But actually on the clinical practice, as I have said, we don't need to inject the contrast for this patient. Usually, when we have a gray scone pyrite, which is a pyrite 3, in this situation, we should inject. This is, I think now, this is the lesions, typical cancer lesion. Don't miss, please, because they are very important. And I think I give you one example for each case, transition zone and peripheral zone. And I think I come to the end, and thank you for your attention and your listening.
For both peripheral and central zone. Thank you so much. Now we proceed to our guest, Professor Anwar Badani. Professor Badani is a consultant radiologist in Mount Vernon Cancer Center in London, professor of cancer imaging, Institute of Cancer Research in London, and trustee of International Cancer Imaging Society, and the co-chair of the International PAARS Steering Committee. Professor Badani will talk about optimizing the prostate cancer diagnosis pathway, case-based review, and sincere appreciation to Dr. Anwar for his valuable contribution. Professor Badani, the mic is yours.
Thank you, Tariq. Assalamu alaikum, everybody. I hope you can see this. If not, just signal me. Okay, so these are my disclosures. Now, what is the prostate MRI pathway? The prostate MRI pathway is this. You can see that this is the publication of the 2004 pathway. And what you notice is it's called a modern risk-based MRI prostate cancer detection pathway, because what you see here is a patient selection here on the left-hand side, an initial clinical risk assessment, followed by an MRI risk assessment, and then a decision to biopsy. So you can see how risk is brought into the MRI pathway on 3 occasions. And in fact, this is the modern MRI risk pathway, which hopefully will get published by the PAARS committee soon. So essentially what you see on the left-hand side is an initial clinical risk assessment here, and there may be other forms of risk assessment that are also done. And what you'll notice is that if somebody has low risk, this green here, they don't undergo an MRI at all. However, as Tariq was saying, if you are intermediate and high risk, then you get a high quality MRI and consistent, important. And here it says computer assisted radiological interpretation. So this is signaling that AI is going to come into this space. And once you have done the assessment, and we've just seen Haitham talk to you about low risk, intermediate risk, and high risk, you have an adjusted risk of cancer, and you use the PSA density. And the PSA density is then used to decide on whether you're going to biopsy somebody or not. So if there's a more than a 10% chance that somebody has a clinically significant cancer, they undergo a biopsy that is MRI directed. So that's why it's an MRI determined biopsy. And if they are negative, then they undergo a safety net. If they're positive, then they undergo a risk appropriate therapy, whatever that turns out to be. Now, you've heard how to read a prostate MRI, but what benefits does it deliver? There are 4 benefits that you should know. And these were referred to by Tariq. So it reduces the number of patients undergoing a biopsy, and it reduces the diagnosis of indolent cancers you do not want to find. And this speaks to this rule out ability. But as we've just heard, it can identify cancers. So in other words, it can give you a more accurate targeted biopsy, and therefore grading is improved. And in fact, it turns out it is not inferior, but in fact slightly superior to systematic biopsy. So there are multiple advantages. And this meta-analysis was published in 2020, and the key statistics are shown on the right-hand side. So you'll see that if you use MRI, about a third of men will avoid a biopsy. So 1 in every 3 will avoid a biopsy. You decrease indolent cancer detection by about 10%, and you do not impair the detection of clinically significant cancers, despite the fact that 1 out of every 3 men will avoid a biopsy. So you can see how this is a real advantage. So what does that mean in clinical practice? So let's say you have a typical urological outpatient. In a typical urological outpatient, when you have suspected cancer, 1 man will have a clinically significant cancer out of every 3. Now, if your colleagues are still doing systematic biopsies, what that means is they are missing in 1,000 men 111 cancers, right? And they are finding benign cancers, indolent cancers or benign biopsies in 700 biopsies. So they're doing 700 biopsies and they don't get a cancer diagnosis. And they miss 1 in every 10 men, which is crazy if you think about it. If you were to use an MRI pathway, what you find is you miss 84 cancers, not 111, right? The other thing you'll notice is that 672 men are correctly identified as not having a cancer and not needing a biopsy, okay? In fact, only 28 men will need a biopsy, and after the biopsy, you'll say you were negative. So you can see the real world impact of using this sort of technology. Now, we talked about the PAARS system, and I'm giving you the latest metadata on this. So the more suspicious you are, the greater is the chance of cancer. So if you have, so this is the prevalence of cancers across the different PAARS categories. Now, what you'll notice is that the more suspicious you are, PAARS 3, PAARS 4, PAARS 5, the more likely it is that you will have a cancer. Okay, so if you have PAARS 5 and you saw 2 PAARS 5 cases, you'll see that 85% will have grade group 2 and 15% will have grade group 1, and no cancer, in other words, nothing there at all, no cancer, only in 3%. Yeah, and this is PAARS 4. So in PAARS 4, 60% will have grade group 2 and above. 41% will have grade group 1, and a very small percentage here, you can see, will have 12% will have a benign biopsy. So you can see how you really need to focus here on the positive PAARS 4 and the positive PAARS 5 cases, as we were just talking about a few minutes ago. Okay. Now, the problem with the PAARS pathway is that, or the MRI pathway, is that there are a number of challenges. As you all know, there are quality issues around the data acquisition. The learning curve is quite steep, yeah, as many of you will know. Too many men need an examination. Now, it may not be that in your case that there are too many examinations, but in my case, I'm getting too many cases to read. And what do we do about men who have a positive MRI and we don't find a cancer? As Haitham was saying, not all men benefit from contrast medium. Yet we inject everybody, but we don't need to. And of course, the problem is on the right-hand side, we are now getting radiological burnout. So how do we start delivering the best for our pathway? And the first thing to do, I'm not sure what's happening, technical gremlins.
Okay. No
Now,
problem.
what sort of man benefits from an MRI? Well, if you look at the 2024 guidelines, what you'll notice is it's the asymptomatic man. Interesting, right? The asymptomatic man, right, in the early detection setting, right? A symptom who has more than a 10-year survival. These people should be assessed clinically. And if the DRE is positive, in fact, they don't need an MRI. They can go directly for a biopsy. So you put your finger up there and it's an obvious cancer. MRI adds very little value in terms of detection. It adds value in terms of staging, but it may not help you in detection. It is these men here, these asymptomatic men who have a reasonable life expectancy of at least 10 to 15 years who should get an MRI. Now, what is the difference between detection and screening? And they are different concepts that you should have in your brain. Okay, so early detection is used to describe any measure to diagnose an individual patient. Right? That is very different to screening. Screening is a simple test applied to a whole population to identify a disease. So everybody gets an invitation in screening. So make sure you don't confuse early detection from population screening. So today we are talking about early detection. So somebody like this, very typical, right? So he has an indeterminate PSA, it's only 7. He clearly has a PAARS 4/5 lesion in the left anterior transition zone. And here's the high B value image, and there's the low ADC map. And okay, so these are the typical men that you should expect to do a whole MRI on. But what we find now, as practice will advance, is that we get a new group of men who are now coming for an MRI. So, for example, you have a man, right, who didn't get an MRI or had a negative MRI and was then discharged, but then continues to have a rising PSA. What do we do about this man? So these men need another MRI. We also have the use of MRI in active surveillance, which is the last point at the bottom. But we're not discussing that point. But these are the groups of men who are now coming for prostate MRI. The next thing you need to do is perform a high-quality prostate MRI. And the emphasis here is quality. Okay? So if you look at the PAARS committee, the PAARS committee in 2011 said that you should perform a contrast-enhanced MRI in intermediate and high-risk men, right? And you'll see that here, the contrast, you may or may not require it. So if you had a high-risk man who is clearly DRE positive, then you probably don't need it. But you have a high-risk man with a negative DRE, then you probably do. So you can see why there is no particular preference. But somebody who is of intermediate risk, you can see there's a preference to using dynamic contrast enhanced MRI. Okay, so these are the guys who need it. Now, it is true, and Haitham has talked to you about this today, that a biparametric MRI is as good as a multiparametric MRI when quality is good and there is expert reading and the whole process is supported by multidisciplinary team decisions, okay, which is what you say here. So at the bottom, you'll say biparametric MRI is good as multiparametric MRI when quality is good with expert reading and multidisciplinary team biopsy decisions. Okay, so I don't want you to go away saying that I don't need to use contrast enhancement, because it will save you multiple times. So if you don't have the best scanner in the world, if you are less experienced or you're not supported within an MDT, then we would still recommend you use dynamic contrast enhancement. But if you are supported, then you can see the difference in this prospective international multi-center study, 22 centers. You can see the data is identical, okay? But look at the quality of the scans. 70% of these scans were considered to be of high quality. Okay, so the quality is, of course, the important decision-making thing. Now, the next thing you need to do, especially if you're going to engage with your urologist, is to know what to do or what to advise a urologist when a scan is positive and when a scan is negative. Let's take this man here. Okay, so this is an obvious PAARS-1, large volume BPH. The peripheral zone is compressed, and there is nothing here. There's nothing to see. This is a negative scan. Now, the question you have to ask yourself is, look at the PSA. The PSA is 18, but the PSA density is low, less than 0.1. Okay, so would you say no biopsy needed? This is obviously BPH. Would you consider doing a systematic biopsy? Do you need to look at the guidelines? Or, as many of you, I'm sure, you're saying, I don't give advice on biopsy. Now, actually, your urologist wants you to engage. Now, if you took 100 of these men and you biopsied them, you can see 3/4 of these men will have a negative biopsy. So no cancer, okay? If you biopsied these men, what you would find is that there would be 18 men with indolent cancers, right? On the other hand, you would find 8 out of 100 cancers, right? What does that mean? That means you have to biopsy about 12 to 13 men with a negative MRI to get a positive cancer diagnosis. And that is a problem. So you're exposing, you can see, over 90% of men to a biopsy when only 8 will benefit. Now, if you don't biopsy, apologies everybody, I'm not sure what's going on. Okay, so what you see here is that if you do not biopsy, you'll miss these 8 men, out of which there will be 3 who will have a higher grade cancer. In other words, grade group 3 and again. And these are the deadly cancers. Now, the question you have to ask is it worth biopsying all of these men to diagnose 3 deadly cancers? Now, these statistics are important for you because when you enter into discussions, you should think about what to do about these men. And one of the first things you can do is to say, okay, if I decide not to biopsy, what would happen, right? Well, these are actuarial tables. And what you notice is that over time, look, this is 1 year, 2 years, 3 years, 4 years. You'll see that these cancers will eventually emerge, but you'll see it's about 5%. Can you see that? Down here. And usually in the first year. So between 1 to 2 years, you will see these cancers emerge, and then no more cancers will come after that. And it's about 5%. If you look at this data, you'll see, again, 60 months is 5 years. You see, very few men will have a cancer that will emerge over 5 years. So in fact, there is good data to say you don't actually have to biopsy these men immediately. Now, what are the flags? The one flag that you should look for is something called PSA density. So in PSA density is shown here. So this is a PAARS 1 and 2. So this is where we're worried about at the moment. You'll see that if your PSA density is more than 0.2, there's more than a 10% chance of you having a cancer. So the discussion with your clinical colleagues, your urologist is, this is a negative MRI, what is the PSA density? If it is more than 0.2, then go ahead and biopsy. If it's less than 0.2, don't biopsy. Now, the interesting thing is, if you follow these men over several years, and this is following over 4 years, so these are men with a non-suspicious MRI and a low PSA density, and this is the population average for a high-grade cancer. You'll see that it's like having a population average. So what we can be very confident about is to say this is a negative MRI, low PSA density, you are no longer at an elevated risk of prostate cancer. So in fact, you could probably discharge these patients because they are no longer at an elevated risk. Of course, if the PSA density is higher, they still remain at a higher risk of prostate cancer. And so you need to follow this. And in fact, if you look at the latest version of the EAU guidelines, it's exactly what they say. Look, when an MRI is negative, i.e. PAARS 2 or less, and clinical suspicion is low, in other words, PSA density less than 0.2, with negative DRE and no family history, omit the biopsy and offer PSA monitoring. Okay. Otherwise, in other words, if you are worried, then do a systematic biopsy. Okay. So very nicely, that dovetails what we are saying in our practices. And in fact, you should read this article, which came out in the AJR, about what to do with a negative MRI. And as radiologists, you should read this to understand where is the data and how you should follow men on what sort of safety net. I apologize, everybody. I'm not sure what's happening. I've asked everybody on my house to get off the internet so that nobody's watching YouTube or anything.
Yes, okay.
Like, and you know, and I pay for an expensive light, so I don't know what to do. Okay, so this is, let's look at a man who's positive. Now, obviously, this is a PAARS 5 lesion. So the question here is not, should I biopsy this person? Obviously, he needs a biopsy, correct? I mean, I don't think anybody has a doubt about this. The question is, what sort of biopsy does he need, right? Does he need systematic biopsy alone, which is what your urologist wants to do, targeted biopsies alone, systematic plus targeted biopsies, and this is what Tariq said to you earlier, regional targeted biopsies, or do you want to look at the guidelines? Okay, so what would be the benefit of just doing a targeted biopsy versus a targeted biopsy plus systematic biopsy? This is the question, okay? And let's have a look at that data. So if you did just target the biopsy of the MRI visible lesion, you would detect almost 40 cancers, 39 out of 100, okay? If you did a systematic biopsy, you would get 5 more cancers, right? You think, okay, 5%, right? But if you just did a systematic biopsy, then if you just did a targeted biopsy would also give you 16 indolent cancers. And if you did a systematic and a targeted biopsies, you will end up with 4 indolent cancers. Okay, so what does this mean? This means that for every systematic plus targeted biopsy, you will end up with 1 clinically significant cancer, and you'll end up with another insignificant cancer, right? So you are exposing a man to additional biopsies to find 1 significant cancer, but you will also harm 1 man. And this is the problem. And this is the balance. So that's why you need to know this data when you talk to your urologists. So what do the guidelines say? The guidelines say, and this is the 2024 guideline, when an MRI is positive, combine a targeted biopsy with perilesional biopsies. It no longer mentions systematic biopsies. So systematic biopsies, which Tariq mentioned earlier, are now gone in 2024. Interesting. So you can see how the guidelines are shifting towards saying, actually, just biopsy the lesion that you see on the MRI scan. And you can use these guidelines in your discussions to say, look, the 2024 guidelines say you should only be targeting the lesion that I see and around that lesion. Okay? So this is what has changed. Now, one of the problems is these indeterminate scans. Okay? And indeterminate scans, surprisingly common. Okay? So in this publication, which I'll show you later, indeterminate scans is 1 in 5 scans. If you look at this meta-analysis, it was 17%, so more or less 1 in 5. And about 20%, i.e. 1 in 5, will have a clinically significant cancer. This is a problem. So 1 in 5 men will have an indeterminate scan, and 1 in 5 of those men will have a clinically significant cancer. So these indeterminate scans are problematic. So how do you deal with these indeterminate scans? Well, the first thing to do is ask a friend, a radiologist. Get him or her to check the quality of your scan, whether you have done a PAARS compliant MRI, check whether you got the ultra high B value, have you given contrast, did you calculate the ADC correctly? And did you apply that criteria correctly? That's the first thing you should do. And here's an example. So the first case, you can call a PAARS-3. The second case has got artifact. You cannot call that PAARS-3. Now, I know people do it because they say, I don't know what to do with this case. It's got artifact. I'll just call it PAARS-3. That's the wrong thing to do. And in fact, the PAARS committee is going to change its recommendation and say, if you get a poor quality scan, you are no longer allowed to call it PAARS-3. You have to call it a PAARS-0 or a PAARS-X, or I don't know what PAARS to give. But you can't call it PAARS-3. Okay? So it depends on the quality. So here's a person on a biparametric MRI. This would be PAARS-3, yes? Not very hyper intense, but it's low on the ADC. Here's the high B value image. This is a PAARS-3 classical. If you give contrast, it's clearly a 3 + 1 = 4. So remember, did you perform a multiparametric protocol? If you just did the biparametric, you'd say PAARS-3. If you put multiparametric, then of course it's a PAARS-4. Now it turns out that if you do peer reviews, in other words, you go to an expert with your difficult cases, how often do you see the changes in the PAARS? Look over here. These are 7 urologists, uroradiologists reading over 650 scans. And you can see these are the PAARS-3 categories. When they were reviewed by an expert center radiologist, you'll see the total number of PAARS-3 cases reduces from 209 to 152. So it's worth asking somebody more experienced. In fact, the number of negative cases increases and the number of positive cases decreases. So when you're not sure, ask a colleague, because it can be very effective as an intervention. Remember to use PSA density. We talked about PSA density for PAARS 1 and 2, but this is really interesting data. You can see how in PAARS-3 cases, so this is 5, 4, and 3, and this is the PSA density. You'll see the higher the PSA density, the greater is the risk of clinically significant cancer. In other words, what we are saying is PAARS-3 cases are strongly modulated by PSA density, whereas PAARS-5 cases, it's cancer anyway. PSA density makes no difference. There's some difference here in PAARS-4, but the biggest difference is here. Look, you can see after a 0.1, there's more than a 10% chance of clinically significant cancer, right? So use PSA density for PAARS-3. The other thing you could do is ask an AI. Now, many of you don't have AI today, but you will certainly have an AI in the future. And here is the same case with a PAARS-3, where the AI picks this lesion up on the basis of the biparametric, not the multiparametric, on the biparametric. So you can see that that multiparametric image at the bottom on the right wasn't really necessary for this AI to pick it up. Now, it turns out that if you use an AI to read a prostate MRI, so in other words, nothing to do with you, just get it to read, only about 3% of cases will be considered as indeterminate. So the AI tends to say nothing or something, plus, minus, very few indeterminate cases. AI, interestingly, does not decrease the number of PAARS-3 cases. It increases the number of negative cases, both for experienced and less experienced, and it decreases the number of positive cases in experienced and inexperienced, but it doesn't change, look, it doesn't change the PAARS-3 category. So is AI going to help you when you read, reduce the number of PAARS-3 cases? I'm not sure it is. But if you just left the AI to do it by itself, then it would not call many cases. Quite interesting data. Okay. The other thing you can do is take this case to an MDT. And an MDT can be very effective at saying a person needs or does not need a biopsy. So you can see this is before and after an expert radiological review. And we said that the number of PAARS-3 cases will go down, the number of PAARS-4 cases will go down, the number of PAARS-5 cases will stay the same. So this is your central review, which we discussed before. But look what happens before and after an MDT. So before an MDT, you can see the number of targeted biopsies goes down. The number of random biopsies actually may go up, right? And you can see that management decisions are changed. So if you're not sure, take these patients to an MDT. And in fact, if you look at the guidelines, you'll see when an MRI is indeterminate, i.e. PAARS-3, and clinical suspicion is low, in other words, low PSA density, with negative findings and no family history, omit the biopsy and offer PSA monitoring, right? Otherwise, in other words, if there are issues, consider targeted biopsies with perilesional sampling. So in other words, it's saying biopsy that area that you are suspicious of, not everywhere else in the prostate. Very interesting and new change in the data. Now, you now have an idea that there are a number of types of patients who need safety net monitoring. Who are these patients? So these are patients who never got an MRI, so never went for an MRI. These are patients who went at MRI, had a low risk, i.e. PAARS-1 and 2, and are being followed up, or had a biopsy that was negative. So you can see there are essentially 1, 2, 3 classes of patients that will need a safety net follow-up. So these are the 3 classes that we talked about. Okay, let's talk about this man who is at intermediate risk and had a negative MRI or had a biopsy and was negative. Okay, so again, we come to this paper, again in the AJR. I recommend you read this carefully because it gives you really good advice. But the important thing is this. If you prospectively follow men with a negative MRI who had a negative biopsy, and you follow them over time, and you can see between a median of 41 months, the prevalence of clinically significant cancers is 3%. Okay, so you have a negative MRI, you follow these people, and they had a biopsy, and you follow them for months and months and months. The risk is 3%, and the background risk is 3% anyway in the general population. So in other words, they are no longer at a high risk. Now, do delayed diagnoses matter? That's the question. The answer is they don't matter. I know we think they matter, but actually they don't matter. Because this data, published in 2023, shows a 20-year follow-up of men with grade group 2 cancers who either had a prostatectomy or had radiotherapy or had nothing, right? Look at them. After 20 years or 17 years here, you can see they're all alive. They're all alive. So you do not need to diagnose these invisible cancers straight away. You just need safety nets to follow these men that are robust so you catch them when they eventually do present. Okay. What about an MRI in a positive case is but a negative biopsy? Okay, so you can see something, you biopsy it, and the MRI is negative. Where's the guidance for that? Well, there is guidance. You'll see a negative MRI a negative biopsy following a positive MRI. If there are PAARS-5, you go and re-biopsy that. Okay, because I remember we said that prevalence of cancer was more than 90%, right? If you get grade group 2 and grade group 1, it's going to be more than 90%. So you need to go and re-biopsy these. And these men can wait. You can wait a bit and repeat an MRI again in 3 to 6 months. If the abnormality is still there, then re-biopsy. So there is guidance around it. Okay? Now, what are the reasons that we see differences between different centers? And in fact, this is quite complex. It's to do with patients and their preparation. It's to do with you and your performance and your MRI scanners and the quality of your scans and how well you interpret. But it's not your fault. In fact, it turns out a lot of the problems are with the urologists, because the urologists are not targeting the lesions that you see accurately. Okay? In other words, it's the team. It's the team that is failing. You are, of course, part of the team, but it's not your fault. So sometimes they'll say it's your fault. Actually, many times it's their fault. Okay? Because you saw the lesion, they missed it. So how do you go about minimizing variations? It's important. So first of all, you need to identify the sources of variability that impact the pathway. So in other words, what is it in your system that's causing the differences in variability? And how do you begin to control the variability? And you do that through standardization, automation, and better teamwork. Okay? Part of that process is what we are doing today, which is getting the performance of the team members, in other words, you, to a higher level through education and training, which is why you are here today. So that's what we are doing today, okay? But we also have to think about monitoring the performance of a system that is diagnosing patients, okay? I just wanted to give you an idea with this data. So this is recent data from this part of London. So this is the west of London and the southwest of London at these 3 centers. My hospital is here in the corner here. Okay. So at these 3 centers, you can see they had, I think, let's see, I think they had 2,000 referrals. And the time from the GP referral to the biopsy was just over 2 weeks. You can see 43% of people avoided a biopsy everybody had a very low rate of urosepsis. The interesting thing here is same day MRI, reporting, clinical review, and biopsy. Now, so I'm not saying you should do this, but I'm saying that's what we do. So in other words, this can only happen if you can assure quality of the diagnostic chain. And the monitoring of the key indices are these. So these are your key indices. What is the patient satisfaction rate? What is the urosepsis rate? How many biopsies after a positive MRI? How many people avoided a biopsy? Okay, so this is what I mean by the key performance indices. Okay, so let's just summarize there. Remember to choose your patients well. Not all patients benefit from an MRI. Make sure you use the right protocol for the right patient. Okay, risk stratify men after a negative MRI and an indeterminate MRI, and specifically use PSA density. Remember, in positive cases, use the MRI as the roadmap to biopsy these patients, right? Remember, you will not detect all significant cancers immediately. And in fact, you don't need to, because you will not harm the majority of the missed cancers in the longer term. But you need to have a safety net in patients who are avoiding an MRI so that when these cancers emerge, you catch them, okay? And remember, you do need to have, I'm just going to give you this five points again. I'm sorry. So remember, choose your men well and make sure you do the right MRI on the right patient. Remember to risk stratify your negative men and your indeterminate scan using PSA density. Remember to use the MRI as the roadmap to target lesions. Remember that you do not need to find every cancer straight away, right? Because you won't cause clinical harm in the longer term. But you need to have a robust safety net in these people who you didn't detect straight away. Very important. You need to assure the quality of your diagnostic chain. And you do that by working together and making sure that you're working as a multidisciplinary team and that you audit the work you're doing so that you can get the best out of your MRI experience. Thank you very much for listening. I hope you found these lessons important for your clinical practice. Thank you very much.
Thank you very much, Professor Badani, for this excellent case-based review.
Okay.
Yes. So, thank you so much, Professor Badani, for. Yes. It was very useful. Optimization of the pathway for the diagnosis of prostate cancer. Thank you so much, Professor Badani, for. Yes. It was very useful. Optimization of the pathway for the diagnosis of prostate cancer. Thank you so much, Professor Badani, for. Yes. It was very useful. Optimization.
Dr. Badani, you hear me? I think you are muted.
I'm here.
Okay, so that's good. Okay. I'm very enjoyed with your pathway because it attacking many problems in our clinical practice. Yes, especially with these the recent guidelines, which can guide us for how to manage our patients. So I have just one question regarding the guidelines when we targeting the specific lesion and the perilesional area. So what's the mean by the perilesional area? What's the extension of this perilesion? And it could be aided a value. If I suppose that if this lesion is PAAR at 5 and the Gleason score more than 7, you do expect that this lesion, or the knee pie area, which doesn't obvious of the MRI, has another PAAR at more Gleason score or higher Gleason score?
Yeah, so you are correct that the perilesional biopsy has just been introduced into the guideline, and it actually doesn't go into it. But essentially, if you have a PAARS 5 lesion, you do not need a perilesional biopsy.
Yeah.
If you have a PAARS 4 lesion, then what they recommend now is between 7 millimeters and 10 millimeters around the margin of the lesion. And the reason is that the smaller the lesion, the smaller the lesion, the greater is the perilesional biopsies that we have to put. Because the problem at the moment is that when we see a lesion, the urologists are missing, and that's why they give a perilesional area of up to 1 centimeter. Okay. Now, in a PAARS 3, what they're saying is it should go out to 1.5 centimeters. Because when you have an ill-defined abnormality, then you do not know where to go.
Mm-hmm.
And so they're recommending something slightly larger. Now, that does not appear in the guideline, in the urological guideline, but it is there in the radiological guidelines. But, it always takes time between radiologists saying something and the urologist adopting it. So at the moment, the step they've taken is to say, okay, perilesional biopsies. And then I'm sure next year we will say by X centimeters.
Okay, yeah, I understand that this is the main issue for this, because the urologist usually apply biopsy. But what if the radiologist apply these?
Yes.
This shift the paradigm or change the guideline?
Well, then it depends on the radiologist and their skill level and whether they're using a fusion biopsy or in-bore biopsy.
Yeah.
So if you're doing in-bore biopsy, of course, you are guiding the needle to the center of the lesion. In that case, the issue is not missing cancers. In that case, the problem is you're over-diagnosing just the most aggressive part of the cancer. Right? So you're up risking a patient. So then to down risk, to get a true risk, you actually, it's better not to do just a targeted biopsy, but actually you do perilesional biopsies. So in other words, up to 4 biopsies per lesion.
Per lesion.
That way, so let's say you have a PAARS 4 lesion and you put a core through it, then you see you have something in front and behind. If you do that this 4 times, then you have a good perilesional core. And in fact, that has now been found to correlate better with the final histopathology.
Okay.
So perilesional biopsies are in fact recommended for both small and large lesions because of the problem with hyperprecise biopsies of inflation. If you just do 1 or 2, then you grade inflate. But if you do 4, then you grade deflate.
Okay. The second question, does the patient has a rule for decision of taking a biopsy, especially in some case scenario you presented, when there is a suspicious MRI, but there is suspicious lab, but doesn't reach the guideline to judge MDT, shouldn't be no biopsy, even if there is a 1 or 2% to have a significant cancer, as you have said. But do you take the patient opinion for such cases, or how do you deal with this?
Yeah. Okay. So there are clearly going to be patients who are what are known as cancer averse and who are biopsy averse. Okay, so let us say, I mean, I had one guy from Iraq a few months ago. His father had prostate cancer. His uncle died of prostate cancer. Okay. And he's saying, well, my PSA is raised. And I'm looking at him and he has a PAARS 2-3, right? And so then the question is, do we biopsy this man or not? Not clearly, he's cancer averse because his father had it and his uncle has died of it. So in that case, we discussed within the MDT and said, look, the chance of cancer is very low, but we need to know what's going on in this PAARS 2 abnormality, right? And we biopsied it, and it turned out to be atypia, okay? So negative. But a 40-year-old man should not have atypia. Yeah? So in fact, although it was a negative biopsy, for this man, it's actually very important because he knows he's at higher risk now. He already knew from a family history. Now he knows he is at higher risk. So in terms of the way we surveil him, then it makes a difference. Clearly, they're going to be at the other end of the spectrum. We'll have people who have PAARS, will have lesions, but they don't want to biopsy. Right? So you can imagine a 75-year-old, yeah, with a PAARS 3 abnormality, right? So he'll say, what's the chance of me having a cancer? And you say 1 in 5. Say, what's the chance of me dying in the next 20 years? And you'll say 0% chance of dying. Then he'll say, why are you biopsying me? Right? So he's biopsy averse. He said, I don't need this. Right? And you can have men with comorbidities who'll say, no, thank you. So you can have, you have the normal man that we are talking about today, but there are going to be people at the extreme spectrum. And that's why this MDT decision is important.
Yeah. Thank you.
Yes. There is 2 questions, Professor Anwar, regarding the PAARS categories. First one, why is 1.5 centimeter size chosen? Second, could you please clarify if there is a limit ADC value that could differentiate in equivocal cases?
Okay. So the reason 1.5 was chosen, it was a flip of a coin. Yeah. What shall we choose? Now it turns out that 1.5 is actually a good figure, because if a lesion is more than 1.5 centimeters and it's against the prostate capsule, then the prevalence of extraprostatic disease increases, right? And so there is definitely a correlation of size versus extraprostatic disease. It turns out that if you look at long-term prognosis, how long people live with a PAARS 4 and a PAARS 5 and a PAARS 3, there's a very nice correlation, right? So it turns out, and of course we know the bigger a lesion, the more likely it is to be an aggressive cancer. So retrospectively, we now know there are correlations. But prospectively, when we were deciding whether to use 1 or 1.5, it was a flip of a coin. In reality, in terms of the ADC value, that is a difficult one. And the PAARS committee has been struggling with this for over 3 or 4 years. And what we have found is that people's protocols vary so much that we cannot fix on a specific ADC value. Because some people do ADC value across the entire range of acquired B values. Although the PAARS committee says, don't do a 0, do 50 to 100, and then up to 1,000 and nothing more. But every day I see people who have acquired up to 1,400 and get the ADC value from 1,400, and that's falsely elevated. And then they will go and publish that And then you think, well, that's a crazy value, right? Because it doesn't comply with the mono-exponential decay. And we've looked at this with phantom experiments and looking at multiple data series. And the problem is the data is not consistent. So in other words, what you have to do is you have to decide in your own scanner. Once you do 20, 30 cases, you'll know. But if I were going to use a ADC value, I would choose an ADC value about 870 or so in my scanner, okay, which seems to work well for PAARS grade group 3 and above. Yeah. So that, and the lower it is, the more likely it is to be grade group 3. So if it's like, let's say 400, 500, then I'm very worried. If it's 1,000, I'm not so worried. But that distinction is not hard enough. And we have looked at this again and again and again in the PAARS committee, and the variability is so much that it's impossible. The other thing about PAARS, about the ADC, it depends on the size of the lesion. So if you have a small lesion, you get a greater error when you draw an ADC. When you have a large lesion, the ADC error is different. So the problem is, if we said use this value, then it would very much depend on the size of the lesion because of the error. And that's a problem. And so that's why we've decided to say nothing.
Okay. And about biopsy of very lesional cores, how many?
So the guidelines is you do between 4 and 7 cores in total per lesion. Now, if you are good at this, 4 is okay, right? So if you're doing in-bore biopsy, then 4 is fine because you can see the lesion, you can biopsy. But of course, not many people have in-bore biopsies. If you're doing ultrasound fusion biopsies, then it depends on the size of the lesion. So if you have a small lesion or a PAARS 3 lesion, then you'll need more biopsies. So you push it up to 7. If you have a PAARS 5, then you don't need a perilesional biopsy. You just need 2 cores to the center and you finish your class. You're done. So
okay.
Size
and I'd like to ask you a last question because we are up to the time of the webinar. Does the PAARS version 2.1 need any modification or addition, in your opinion, to get a better optimization?
So there's no doubt that we need it. The problem is we are not allowed to do it. And so the issue is that once you have a system that is in the clinical guidelines, and you can see it's already in the EAU guidelines, and the word PAARS is mentioned in the guidelines. Once you get to that stage, any change you make could have a detrimental effect on patient outcomes because they will change, right? So any change that you make, you have to assess the pathway impacts of the change. So let us say we change the guideline, instead of saying read T2 first and diffusion second in the transition zone, if I say let's do it the other way around. Let's look at the diffusion and then do the T2. Let's say we do that. Just that simple change. That is problematic because the number of false positives changes. The number of biopsies will change. The outcomes will change. So the bar to change even something minor, what we think is minor, could have multiple consequences for the patient's pathway and may make a useful test into a useless test because of the confounding variables along the pathway. So in other words, we have to do simulations of the pathway, right? Or we have to do or we have to do a multi-center clinical trial that is randomized to show the differences. And that sets a very high bar to changing something. And that's a problem. We can do that with LIRADS because LIRADS is not in the guidelines. The PAARS is in the guidelines. And this is the problem.
Yeah. Okay, thank you so much. It was very useful, and we appreciate your time and effort, and we look forward for more cooperation between you and the Pan-Arab Association of Radiological Societies. And with this, I conclude the webinar, and thank you all. Thanks for the audience and for ICOM and for Haitham, and see you soon, inshallah. Thank you. Assalamu alaikum.
Assalamu alaikum.
Thank you. Assalamu alaikum.